Dear colleagues, ladies and gentlemen, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. My name is Nicolas from Mieghem, next to me my good friend and colleague Joost Daemen, and today we're going to preview the late-breaking clinical trials for the upcoming ACC meeting 2025 in Chicago. Joost, why don't we start with three structural heart trials?
Yes, let's do that. So first is the PROTECTED-TAVI trial.
Yeah, and this one is in my opinion, the most anticipated trial, not because we don't know the outcome, because the outcome we already know that the DSMB terminated this trial prematurely. It is a study that will be presented by Raj Karbanda from the UK. More than 9,000 patients from the UK were randomized one-to-one to use of a systematic cerebral embolic protection or TAVI without cerebral embolic protection. So this should be the definite trial on the topic of filter-based cerebral embolic protection with the Sentinel device. The primary endpoint, any stroke at 3 days. And as mentioned, the trial was stopped prematurely by the DSMB because there was no efficacy and there was also questionable safety. I think we are all very keen on learning more. What are the details of the trial and were there any signals in any direction? There is also a pooled analysis planned that will pool the data from the UK PROTECTED-TAVI trial with the PROTECTED-TAVI trial from the United States. Another 3,000 patients will be added. So I think we will get a definite answer at least on whether cerebral embolic protection with incomplete filter-based embolic protection has an effect on clinical neurological events.
Yeah, that's it. I have a little more to add, besides the fact that obviously in the PROTECTED-TAVI there was a signal towards less major strokes. Let's see if there's a signal in this trial as well.
Yeah, and what about the safety? Is there a safety signal?
That's something we haven't seen before. Maybe I'm curious to see what the reason will be that the DSMB halted the trial in terms of safety.
Yeah, and I always said, and I will repeat myself, nobody is disputing that by using these filters you will capture debris in almost all the patients undergoing TAVI. The question is, are we now looking at the right endpoint? Because there may be effects in terms of neurocognitive function that we're not testing at the moment. So hopefully this is not the end of cerebral embolic protection, because once you are a TAVI operator, I mean, we have seen it. We see debris if you put these filters under the microscope in all the patients. Yeah. So it is worrisome, I think.
Yeah, exactly. But with an endpoint that's 72 hours, I mean, I think it is perhaps a missed opportunity to follow these patients for somewhat long run term to test also neurocognitive decline on the longer term. Yeah. Because that's likely a question that this trial will not address.
Yeah. Yeah. The next study is the Evolut low-risk randomized controlled study, and this time the 5-year outcome data will be presented by Michael Reardon. I think it's an important trial. Remember, the Evolut low-risk randomized controlled study was evaluating TAVI with the supraannular functioning Evolut valve versus surgery in over 1,400 patients at low operative risk. There is also a continued access program, including up to 3,660 patients, so added to the randomized study. Well, the primary endpoint at 2 years was there was non-inferiority between TAVI and surgery, and at 4 years, the Kaplan-Meier curves were separating in favor of TAVI. So it's going to be very important to know and to learn how the 5-year data will look like. And do we see these curves separate even further? And this would be at odds with the Partner 3 low-risk trial, obviously, where the curves, the Kaplan-Meier curves, were more or less on top of each other, but maybe even in favor of surgery. So I think this might become a very controversial data set that will also spur a lot of discussion among panelists and among cardiologists and surgeons. What do you think, Joost?
No, I totally agree. I think this is one of the studies that will definitely provide very, very, let's say, relevant data on the performance of these devices in lower risk patients. I mean, this is the continuing debate to use TAVI in lower risk patients, younger patients, because of patient preference simply. This trial, at least with respect to the Evolut device, will shed important details on the safety in respect to as compared to surgery. I would like to urge a word of caution when comparing this to Partner 3. I mean, these are obviously different trials, although they were performed relatively in close proximity to each other. The enrollments were more or less overlapping. This is not a head-to-head comparison of Evolut versus Sapien. But that said, let's see what the results of the long-term use of Evolut will show.
Yeah, and I agree with that. We should be very careful comparing the two randomized controlled studies. Just look at the outcome of surgery. It's different in the Partner 3 trial versus the Evolut low-risk trial. So be very careful with comparing these two randomized controlled trials. And then the third trial in the structural heart space was the Triluminate pivotal trial. Sable Carr will now present the 2-year follow-up data of 350 patients that were randomized 1-to-1 to tricuspid TEER for severe tricuspid regurgitation or control. At 1 year, tricuspid TEER reduced, obviously, tricuspid regurgitation to less than moderate, less or equal to moderate in 87% of the treatment arm versus only 4% in the control arm. And the improvement in Kansas City quality of life was by 12 points in the tricuspid TEER arm versus no improvement with control. Numerically, there were more hospitalizations with TEER, and there were no effects on overall mortality. So now the results at 2 years become very relevant because these effects on quality of life, are they durable? And will they eventually translate also into better clinical outcomes? Unclear for me at the moment. I think this is an interesting follow-up study. Obviously the trial was not powered for the 2-year endpoint, but notwithstanding this limitation, I do feel that this trial might provide a little bit more information on whether we need to be more aggressive relative to tricuspid regurgitation.
Yeah, that's true. That's true. But let's see. I mean, there has been a lot of debate recently as to whether the focus of the endpoints really shifted with these kind of trials, specifically in the tricuspid space, to softer endpoints, improvement in quality of life, but no improvement in heart clinical endpoints, no real improvements in reducing rehospitalizations. But if this, by the way, may translate on the longer run in a difference, that would obviously, let's say, settle the debate a little bit and would be indeed in favor of being more aggressive. And conversely, if this is not the case, and also the quality of life at the end will come down altogether, then you could wonder how effective this treatment is, right?
Well, I think it's also important to realize what the crossover rate will be. How many patients in the control arm will eventually get a TEER? And the most unfortunate part of these tricuspid trials so far is the absence of a sham control. Because there is this Hawthorne effect that once you know as a patient that you received a therapy, that by itself might result in improvement in quality of life. So I don't think this trial will give us a definite answer. So let's move to the coronary space, flavor 2.
Yeah, so in the coronary space, a couple of interesting trials we wanted to highlight. One is the anticipated flavor 2 trial. So this is a prospective, multi-center randomized controlled trial, really designed to assess whether a angio-derived FFR strategy, in this case using MuFR, so the angio-based physiology index of Pulse Medical, is non-inferior to a IVUS-guided PCI strategy in patients with intermediate coronary artery disease. So basically the trial will enroll over 1,800 patients with lesions with a diameter stenosis above 50%. 1-to-1 randomization for the FFR or MuFR arm. It's obvious. Below 0.8 is randomized to PCI. Those patients will get treatment. Whereas in the IVUS arm, obviously an anatomic criterion for revascularization will be used, being a MLA below 3 or a MLA between 3 and 4 together with a plaque burden above 70%. So exactly identical to what we've seen in flavor 1. Which basically assessed the non-inferiority of FFR with a conventional pressure wire-based system to IVUS, and concluded there was basically no difference. So in that perspective, I think the results of flavor 2 are of interest. A couple of things that I think we need to be careful with. One is that flavor 1 was a Chinese-Korean trial. Well, the flavor 2, I think, basically ended up as a Chinese trial only, as the Koreans did not get approval for MuFR in time. Second, sample size calculation, somewhat different, about 8% primary endpoint events in flavor 1. But now the trial is powered at 1 year with this more or less the similar event rate. So that I don't completely get. But that said, I think an important trial that will shed more details on the safety and efficacy on the use of angio-based physiology. In this case with the MuFR system, which is more or less like the META system that recently failed to show non-inferiority or actually superiority as compared to a angio-guided approach in the Favor 3 Europe trial. So with that in the back of our heads, I think this is definitely something to look out for.
Yeah, that's one of the major limitations, that these geographical restrictions, if you will. If it's limited to a Chinese population, multiple questions will then arise. But okay, I think it is important to keep doing these studies based on angio-derived FFR, because that definitely is still technology in the uprise, if you will.
Yeah.
FAME 3, 5-year results.
Yeah, 5-year results of FAME 3. So not much novelty here. You all recognize FAME 3, the large randomized controlled trial that randomized 1,500 patients with multivessel disease to either a FFR-guided revascularization strategy versus CABG, and actually failed to meet its primary and non-inferiority endpoint, showing that CABG was actually superior at 1 year as compared to a FFR-guided PCI strategy. Basically due to numerically higher rates of each of the individual endpoints, but mostly because of higher rates of repeat revascularization in the PCR, as we've seen in multiple PCI CABG trials in the past. Frederik Zimmermann already presented the 3-year results a couple of years ago, showing that there was basically no difference in the primary and in the endpoint of death, MI, and stroke, so the hard clinical endpoints, showing a more or less equipoise between the two treatment strategies. However, numerical and even statistically higher MI rates in the FFR-guided treatment arm. Now, patients are being followed up to 3 years, so I assume that will again be focused on death, MI, and stroke.
5 years.
At 5 years, apologies. But I do not anticipate major changes in the findings that were already presented at 3 years.
Yeah, and the implications of this trial are limited, in my opinion, as we already discussed in previous wrap-ups. The fact that intravascular imaging was underused is really a major limitation. This is not standard of care, state-of-the-art PCI techniques being used in this trial.
Absolutely, and I mean 1,500 patients, 48 sites. I mean, these patients were really highly selected, first by the operators and then even in the heart team. So I think it's an important trial, but of course, like most trials, has its limitations.
So talking about intravascular imaging, there is the Eclipse trial, a sub-analysis from that study.
So Eclipse you all recognize, presented by Ajay Kirtani last year at TCT. The important trial to assess whether orbital atherectomy was superior to a angio-guided or to a mostly balloon-based PCI strategy in patients with heavily calcified lesions. So over 2,000 patients with either stable angina or stabilized ACS were enrolled. And then the primary endpoint of the trial appeared to be completely neutral. So basically overlapping event curves with respect to target lesion and target vessel failure at 1 year. But also, and that perhaps was even more striking, that the co-primary endpoint or secondary endpoint, if you will, so being minimal stent area post-intervention, was completely similar between both treatment arms. So that was to me a striking finding. But in this trial, as opposed to the low use of imaging in FAME 3, imaging was used in 62% of the cases. So there is a more or less a subset of 1,200 patients within Eclipse that underwent image-guided PCI treatment, mostly due to the mandated OC2 subarm of, I think, 680 patients. So I look forward to these findings because in this presentation, Ajay or one of his co-workers will present the findings of the core lab, in which I really did a lot of efforts to try to dig into the imaging findings in order to find any specific subset of lesion complexity or calcium morphology that actually benefited from an orbital atherectomy strategy versus a balloon-based strategy. However, given the fact that the primary endpoint was completely neutral, no signal at all, I don't expect also in this trial not groundbreaking findings, but let's see. It's I think an interesting study, and will be definitely the largest thus far digging into the potential of atherectomy versus balloon-based stenting in patients with calcified lesions.
Well, I think that orbital atherectomy only benefits a very selected group of patients, and this really is part of patient-tailored strategy selection. There is no point in treating consecutive patients with orbital atherectomy, and so that's one limit. That's one issue, I think, with that trial. The other one is that these were highly selected patients up front, and probably the patients who would benefit most never entered the trial because the participating investigators, they didn't want to randomize those patients, and they said, no, this patient needs to be treated with some kind of atherectomy. So they didn't want the patients to be randomized to the control arm. So I think there are some inherent intrinsic limitations to this trial that are very difficult to solve, and that will be the recurring criticism to that study, I guess.
Yes, unfortunately. Good. ALT-SHOCK-2.
Yeah, so now we move to the heart failure population, and the ALT-SHOCK-2 is an interesting trial because it evaluates the use of intra-aortic balloon pumping in patients with acute decompensated heart failure and cardiogenic shock who are in need of vasopressors. So patients are 1-to-1 randomized to either the use of balloon pump or control that just includes vasopressor support. 100 patients from Milano will be or should be included in the trial. The trial started in 2020. Patients had to have an ejection fraction less than 35%, and they were in shock sky B to D. An important exclusion criterion: this is not related to patients who have an acute coronary syndrome. So patients who had a myocardial infarction within 1 month of enrollment were excluded from the study. The primary endpoint is twofold: survival at 2 months, and also bridge to transplant or LVAD at 2 months. I'm questioning the power of this trial. This definitely should be underpowered for a mortality endpoint. And at the same time, I'm wondering whether they were able to find the number of 100 patients in the time window from 2020. So I think it's very challenging. And then how to interpret these data in light of danger shock and ECLS shock. It's going to be a little bit of a tough one here. That said, we are also doing a trial related to balloon pumping. It's called IBP on time, where we only focus on patients with shock sky B and C. We feel that shock sky D is already a bridge too far for balloon pumping, and you need probably more potent mechanical circulatory support in those kind of patients. But we'll see what the results are. I find this trial definitely of interest, and there is a sweet spot for balloon pumping, and I think that is the challenge for the medical community now, is try to find that sweet spot where a balloon pump makes a clinical difference.
Yeah, this definitely is an interesting trial, but I agree with you with respect to the sample size. I mean, we've done mechanistic studies showing the benefit of balloon pumping. There is currently no consistent body of evidence supporting the use in terms of really improving clinical outcome. This trial may answer that question, but I agree with you that in 100 patients that is not so likely. But we'll see. I think we will at least end up with another trial that will again reflect on the potential of balloon pump in these patients.
No major cardiology meeting without some studies on dual antiplatelet therapy or antithrombotic therapies.
Yeah, so there are two important Korean trials on the agenda. One is a stratified randomization study to compare different duration of dual antiplatelet therapy after coronary stenting in either high or low risk bleeding populations. A study that will be presented by Yoo Kim from South Korea. So to start, I'm not sure if this is actually a new trial or whether this is data from the HOST IDEA trial. So as you recall, the HOST IDEA was a prospective multi-center randomized controlled trial to determine in a 2x2 factorial design initially whether there is a difference between either a short or long-term DAPT strategy, so 3 to 6 months of DAPT versus 12 months. So again, in this case, the 12 month was differentiated by the longer term use of the P2Y2 inhibitor. Again, and then patients were randomized to 2 types of thin strut DES, like the Orciro and the CoroFlow device. 2,000 patients, stable angina, non-stable non-ST segment elevation, ACS. Primary endpoint was already presented, being NACE, which was not significantly different between the 2 treatment arms. However, as anticipated, less bleeding in the DAPT arm in this, again, Asian Pacific population, which is an important nuance to the results of the trial. And with respect to the stent platforms, also already findings that were presented with superior outcome with the Orciro stent as compared to the CoroFlex device. Yeah, so obviously a large trial in which this concept was tested. So again, I'm not sure whether now the investigators will really focus on different subgroups within the trial, stratified to either high or low bleeding risk, or whether this will be a new trial. So that's something we will definitely reflect on in the wrap-up.
Yeah, limited novelty with comparison of 12 months versus 3 to 4 months of DAPT. We're already to another level now. We are now comparing 12 months versus 1 month or even 0 DAPT. I think that is the future, and trials are already ongoing.
Yeah, a similar trial on the topic is clopidogrel versus aspirin for long-term maintenance monotherapy in patients with high ischemic risk after PCI. So again, I'm not sure if this is a new trial or whether this is again a subgroup focus of the, in this case, host exam extended study, which in my opinion was a very interesting study, because this trial basically looked at a subset of over 5,000 patients that were brought back into the clinic, and if they were event-free at 1 year, they were randomized either to long-term continuation with aspirin or long-term continuation with clopidogrel. And what happened is that at a median of 5.8 years, the primary endpoint being death, MI, stroke, or bleeding, occurred significantly less frequently in the patients that were randomized to the clopidogrel arm, so 12.8 versus 16.9%, due to both lower risk of thrombotic events and bleeding. Interesting, and this trial was published, an editorial by Davide Capodanno, who actually also reflected on the topic and also put the results into perspective to the fact that there is not that much evidence on the topic, and the actually only evidence that is available on the topic is stemming from this trial in, again, a Asian Pacific population. That's one. Second is that there may be a difference in interpreting results in terms of different patient profiles that may rather benefit from one drug versus the other. But again, not sure if this is what the investigators will address in a subset of this patient population within this trial, or whether this will be a new trial.
More than 20 years ago, we had the Capri trial that compared aspirin versus clopidogrel in patients at high risk for events. It was peripheral disease and coronary artery disease. And also in that particular study, clopidogrel was outperforming aspirin. So I don't know whether this is so dramatically novel. And what I'm a little bit surprised about is that there is no genetic testing for clopidogrel responders.
So that's a
missed opportunity.
Definitely a topic of discussion per se. I mean, a lot of trials have shown that this is relevant in a lot of patients, but if you look in this large patient subset, so taking it all together, clopidogrel is still superior. So anyway, more on drugs.
More on drugs, but this time in the context of TAVI, of transcatheter aortic valve implantation. There's an interesting study coming from Spain. More than 1,200 patients after successful TAVI have been randomized in 40 sites to either dapagliflozin, so an SGLT2 inhibitor, or control, if they had a history of heart failure with a depressed LV, less than 40% ejection fraction, or diabetes with a normal or mildly reduced kidney function. The primary endpoint is the incidence of mortality or worsening heart failure at 1 year. So basically this is a heart failure study, if you will, after a successful TAVI in patients with aortic stenosis. So I think it's an interesting concept. Whether it will give us answers to whether we need to prescribe SGLT2 inhibitors after TAVI in all our patients, that remains to be seen. So let's see what they're gonna present and what the relative proportion of patients is gonna be with an ejection fraction less than 40%. Because otherwise it's just heart failure, and then there is no reason why we should not be prescribing the SGLT2
That was
inhibitors.
my question. I mean, these patients basically already have an indication for an SGLT2 inhibitor. So yeah, from that perspective, I agree.
But the patients will be older than the typical patients in heart failure trials, so it might also be of interest to see how these SGLT2 inhibitors perform in, for instance, octogenarians. So an interesting trial, so kudos to Dr. Amat Santos and his colleagues. And then if we are talking about heart failure, Stefan Anker is going to present the FAIR-HF2 trial results. And this is, I think, an interesting trial evaluating the use of iron therapy, so IV iron therapy in heart failure patients, HFrEF patients with it, so depressed LV function, whether we need to correct the iron deficiency despite the fact that there is no anemia. I think this is an interesting concept that has already been studied in multiple randomized controlled trials. So we have the AFFIRM-AHF, the Ironman, and the HEART-FID trials. But those trials failed to show compelling benefits with intravenous iron therapy. But the question there was, okay, but were they given enough iron therapy? And I think this is an important comment, and this is where this trial comes in. It tries to fill in that gap. So patients, so more than 1,100 patients will be randomized 1-to-1 to either IV ferric carboxymaltose therapy or placebo. And the iron therapy is different from the previous trial. So patients will receive up to 2 grams of intravenous ferric carboxymaltose, and then every 4 months another 500 milligrams if they don't correct the iron deficiency. So patients will be followed up more meticulously in that trial, and they have clear targets in where they want to go in terms of the iron deficiency. The primary endpoint is a follow-up at 2 years with the time to first event of cardiovascular death or heart failure hospitalization, and another endpoint is looking at the total number of heart failure admissions. So I think a relevant trial that may shed new light on the use of intravenous iron therapy in heart failure patients.
Yeah, that's it. I know you're a big fan of the topic. I have to say, I'm not so sure. I mean, in non-anemic patients, I mean, is it prevention of in case they get ill or get anemic or get a bleeding, or, I mean, I find it conceptually difficult to understand what the benefit would be based on. But again, another large trial in a subset of patients that usually does have events. So let's see.
Yeah, and as a matter of fact, we are also doing a similar trial. It's called Iron-TAVI in patients who undergo TAVI for severe aortic stenosis. When they are non-anemic but have iron deficiency, we're also randomizing those patients, and we are using the exact same treatment algorithm as being used in the FAIR-HF2 trial. So let's keep an eye on the results of that trial. The last trial that we want to discuss is the Fresh Up RCT. This is another trial in patients with heart failure stemming from the group in Radboud here in the Netherlands, where they are randomizing patients who have stable heart failure. So a heart failure admission within 3 months is an exclusion criterion. And those patients, so 500 patients, will be randomized 1-to-1 to a fluid restriction or more liberal fluid management. And so the fluid restriction is a restriction to 1.5 liters per day. And the endpoint of the study, the primary endpoint, is a change in KCCQ, so quality of life at 3 months. Secondary endpoints include the effects on NT-proBNP, death, heart failure, admissions, and so on. I think this is conceptually an important or an interesting study and a practical study that aligns with contemporary practice, because this is what we are telling our heart failure patients, right? They have to limit the fluid intake to 1.5 liters per day. Now let's see whether there is some better scientific underpinning for that statement.
Yeah, I really like these kind of studies. I mean, it's a very relevant topic that we all deal with on a basically daily basis.
Yeah.
But I mean, this is a randomization to a recommendation. And I mean, if you give patients drugs, you know that half of the pills are not even taken. So, and this is a lifestyle recommendations like salt intake, reduce salt, etc. And this is even much more difficult. So, I dare to say that this will be a positive trial because, yeah, basically patients do whatever they want in the vast majority of cases, unless they are really, really, really end-stage heart failure candidates or patients. But let's see. I think it's a nice study and original concept.
But the methodology is going to be important. How do you follow up and make sure that the treatment arm is restricted to 1.5 liters per day?
You can't.
Yeah.
At least that's what I think.
Okay,
but we'll see.
Interesting stuff to look forward to at the ACC 2025, and we'll be back for a wrap-up after the meeting. Thank you very much for your attention, and see you later.
Thank you. Bye-bye.